serving as the allocated session assistant to ensure a seamless experience. LearnNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that LearnNet serves as the digital partner for this event, hosted by the National Neonatology Forum Gujarat. And the focus of today's session is the POCUS Series 20 Normal Views in Head Ultrasound. So let's begin today's session, for which I would like to invite Dr. Vishal Goyal sir to take over. Over to you, sir.
Thank you, Monica. Thank you so much. Good evening, everyone. And I would like to thank first our secretary and the president, by which we can continue this great Pathshala since 2-3 years. And before I start the session, I would like to introduce our president, Dr. Nirmal sir. He does not need any introduction. He is very senior and neonatologist and pediatric intensivist from the Surat. Before I start the scene, I would like to request Nirmal sir to say a few words. Over to you, sir.
Good afternoon, everyone. It is a privilege and pleasure for me to join with this Pathshala series. I'm the president in 2025, and this is first session I am attending in 2025 of Pathshala. And for last 2 to 3 years, this program is going on. It's so important for the pediatrician practicing neonatology and the neonatologists and the fellows, and it's very helpful. And with each session, there is some good topic discussed here with the experts. So I wish you all the best for today's session of POCUS Mid-Head Normal Views of Head Ultrasound. All the best. Thank you.
Thank you, sir. So before I start the session, I would like to introduce today's expert faculty. Kunal Ahya is a good friend of mine. And as a person, I think he is very good clinician as well as the academician. And if I give the brief introduction, he is a MD pediatric and followed by he did in fellowship in neonatology from Pune, and followed by he started the venture at Rajkot, Mahi Newborn Care Center. And he is one of the great center in the Saurashtra region, and also he is associated with the NICU Rajkot. He is currently the secretary of Gujarat at NNF 2024 to till now. And I would like to congratulate him that he is now president-elect for AOP Rajkot from next year. He's also editor. He was also editor of a Neoblaze 2022, and he was also secretary of AOP Rajkot 2018 to 2019. As we know, he's a great clinician and academician. He already published not only the national but as well as the international article and paper presentation. He's also author for chapters in various books, including Kluhati and other two neutral books. He's also EB member of various organizations like NNF Gujarat, AOP, and INA. And if I talk about his passion, not only the neonatology, but particularly he is very much active in the neohemodynamics and neonatal ventilation. So I welcome Dr. Kunal Ahya, and over to you.
Thank you so much, Vishal, for the kind introduction. Thank you, Gujarat NNF, though I am a part of it, only I am the secretary at present. But still, thank you for this opportunity. Thank you to Nirmal sir for being present on this day, and we are happy to be leading NNF Gujarat under his able guidance. Thank you so much, sir. So today we are starting with our neonatal POCUS series, which is neonatal POCUS series number 20. And thank you also Mohit sir for this opportunity, because he's been conducting this since last I think 2 years or so. So this is the 20th POCUS series. So today my topic is about the normal anatomy and views in head ultrasound. So we start. We all know, just briefly we had discussed this so many times, but to just touch up again. So basically ultrasound are the waves which are above the human hearing audible range, which is over 20,000 cycles per second. What we use in clinically is the beams that can pass through the tissues and we get the images on the screen. And normally for the diagnostic purposes, we use the frequency between 2 to 10 megahertz. As you can see in this picture that waves are transmitted, but the reflected waves are coming at different times. So this the transducer of the ultrasound, that is the probe of the ultrasound, sends some signals, but it creates the images based on the reflected waves which it gets, and the time difference between the waves creates the image exactly, and it also indicates what is the distance between the different organs. So there are basically two main components of our ultrasound machine. One is the probe and second is the ultrasound machine itself. So basically first we'll talk a brief about the transducer. So which kind of transducer do we use in our head ultrasound? First, usually we use is the multi-frequency transducer, that is between 5 to 10 megahertz. In most circumstances, 7.5 is the ideal. But in extremely premature babies, as we have previously learned, that the more the superficial the structure, the higher the frequency is required, and the deeper the structure we want to study, we use lower the frequency. So it is opposite. So in an extremely premature babies, we want to see more of the superficial structures. They are small in structure, so we need a greater clarity. And as the size of the baby is small, we need a higher frequency probe. And in a full-term baby, we require a lower frequency probe. So in a multi-frequency probe, we can adjust the frequency of the probe so as that we can get a better image on this thing. So what is the kind of transducer that we use? There are various kinds like sectoral, linear, curvilinear, or array. But what we use is the sectoral, that is the commonest. Why we use it? But the one reason is because it is usually used in the echocardiography, which is our primarily why we are purchasing the ultrasound machine. So from the same probe, we can do the brain ultrasound also. We need not have multiple probes also, but if because they are very costly. But if we can afford that, then we can have a linear probe also, which can get a better image for our head ultrasound. Second is the marker on the probe. There are different kind of probes have different kind of markers. That is, there can be a ridge, there can be a light on the marker also. So in echocardiography, what we had learned it is we put the probe marker according to the clockwise position. That is either on the 3 o'clock, 6 o'clock, 12 o'clock position. But for the head ultrasound, we have basically two main positions are there. One is the right side of the baby, or either on the anterior side. So these are only the commonest two positions in which we keep our probe marker. Then there are various positions through which we move our probe. They are named like, one is tilting, in which we are referring to the foot plate, that is the lower end of the probe. So if it is moved front or back, then we call it tilting. If we move it side by side, it is called as angulation. If we are rotating the probe, then it is called as rotation. And if we are moving the whole probe from one end to the other end, then we are calling is a moving the probe. So these are the basic standard nomenclature which we use if we want to do the motion in the probe. Then again, how do we hold the probe? The marker is usually placed on the right side and you should secure your hands. How do we secure? So here you can see, I'll just use a marker. So here you can see that we have hold the probe like a pen, and three of our fingers are rested on the chest of the baby. Or if we are doing an head ultrasound, they are rested on the head of the baby. Why? Because we do not want unnecessary movement of the probe, so that we can get a very clear image, as well as undue pressure is not applied on the baby. So we should maintain that, and sometimes the baby might get very irritated, so we should stop at that moment and we should keep on practicing those so that we can get a better and a clear image. Then by selecting, we should be selecting a brain or neonatal brain ultrasound preset is there, which is being set by the company person or the application specialist from the company whichsoever you have bought from. So you should select that, because if you are using an echocardiographic, the gain and everything is not set as to get a clear image. So in a head ultrasound, we need to use first the right probe, then the right preset. Then now coming to the clinical part of it, when do we do head ultrasound? So indications are very in all these premature babies. I will go into further detail in the next few slides. we usually screen because the chances of intraventricular hemorrhages are quite high in premature babies. So we routinely screen in the premature babies, especially in those who are sick. If there is a sudden fall in hemoglobin or the size of the head is enlarging a lot, we do evaluation for the babies who are having microcephaly, as well as in those babies who are having proven or suspected meningitis or ventriculitis. We look for intraventricular hemorrhages, and in those babies who are having hydrocephalus or post-hemorrhagic hydrocephalus, we do serial monitoring so that we can decide whether we need to intervene in those babies or not. So serial follow-up of the babies who are having post-hemorrhagic hydrocephalus. For evaluation of the babies having neonatal seizures, those babies who are having hypoxic ischemic injury, traumatic or difficult delivery, large bogey swelling in the scalp, or sometimes unexplained congestive cardiac failure. Few years back, I had a patient who we had initially diagnosed at PPHN, and when I put the probe on the scalp, I came to know that there was a large vein of Galen malformation that was causing it. So sometimes you find some unusual things also on the head ultrasound. So which baby should be screened? Any baby who is less than 1500 grams or 32 weeker, all the babies should be screened. If the baby is above 32 weeker or more than 1500 gram and having the risk factors like asphyxia, pneumothorax, abnormal clinical signs, all the ventilated babies should be screened. So when to screen? Any baby who is less than 28 weeker or less than 1 kg, or any baby who is more than 28 weeker but less than 1500 gram and is requiring life support. In those babies, you should do it at 6 hours of age, so that you come to know that whether there was any intrauterine event that has caused. So it is used for the medical legal purposes, anywhere between 3 days to 1 week, because that is the commonest time period in which you get the brain hemorrhage at 4 weeks of age. And then later on, because you want to see for the periventricular leukomalicias, and at term equivalent gestational age also. If the baby is more than 28 weeks, between 30 until 32 weeks, or between 1 to 1.5 kg, you do it at between 3 days to 1 week at 4 week and term equivalent. Or if the baby is between 32 to 34 weeker but is a monochorionic twin, head circumference less than third centile, ventilated, requiring surfactant, acidosis, Apgar is low, or hypotension is there, then you need to do it in this kind of babies. Then where do we put our probe? There are specific sites on which we put our probe. Those are the sonic windows, because if you put your probe on the bone, you will not be able to see the structures which are below them, because bone is a bad conductor for the ultrasound waves. So your waves will directly get reflected from the bony structure. Hence, you need to have a sonic wave window, which is a fibrous tissue there. So commonest sonic windows are the anterior front tunnel, which is the most common one, which we routinely use, and rarely only we use posterior front tunnel, the mastoid that is behind the ear, or the sphenoidal, which is in front of our ears. So remember one thing, brain is a 3-dimensional structure, but we are viewing it in a 2-dimensional view. So we have to always mark if there are any issues are there or any defect we are detecting, then we should always do it in 2 planes, and commonest is the anterior front tunnel. So how do we scan? So basically in the anterior front tunnel, we do 2 major views are there, that is the coronal views and the sagittal views. So there are 6 standard coronals and 5 standard parasagittal views, and we go from right to left, and in frontal, from frontal to occipital, that is from front to back. These are the common how we proceed in all the head ultrasounds. So whenever there is a probe is placed in, you have placed it exactly in the center and exactly in the plane also, then also there might be some asymmetry be there, that is physiological, but you need to angulate your probe so that you get a more symmetrical image. Again, the probe, what I had mentioned, it has to be, the marker has to be on the right side of the brain, right side of the baby, and the marker which we see on the screen should always be on the observer's left side. So like this, we can see in the baby, the marker is on the right side of the baby and the marker on the screen. So this is the marker. So you can correlate that this is the, if there is any lesion present over here, that means the lesion is present on the right side of the brain. Okay, so you should orient the marker on the baby as well as the marker on the screen. So marker on the screen is on the left side, while on the baby it is on the right side of the baby. So basically now coming on to the actual views. So we are having coronal views, then sagittal views, and rest all the views we'll discuss in brief. So coronal views, there are basically 6 planes which will be crossing. So this is the plane. So your beam which is passing. So it is the ultrasound beam goes and cuts all the structure, and you can see what all comes in the way of the ultrasound wave. So first is from the frontal cortex, second from the frontal horn of the lateral ventricle, the foramen, this is the foramen of Monro. So between the foramen of Monro, then cutting the middle of the ventricle, posterior ventricles, and the occipital horns. So this is how your probe moves. So we'll start from the front and go to the back. So from the frontal to the occipital. So this is how your probe should be tilted. So this is the anterior front tunnel. So it will start the beam. We will start from the front and gradually we will move our probe posteriorly. Similarly, so this is how it will be actually cutting the brain. So this is the first view when we get. So we put our probe on the frontal anterior front tunnel, and we will be passing. It would be tilted towards the nose of the baby. Hence, this is the structures we will be seeing. So the white bright line which we see crossing, dividing the right and left side of the brain is the interhemispheric fissure. Then on either side of it is the frontal lobe, and below is the orbital ridge. Similarly, you can see this is the orbital ridge, this is the frontal lobe, and in the central part we see the interhemispheric fissure. So we have to see all the 6 views. That is the standard method of doing it. We start from the anterior, that is from the frontal, and go directly back to the occipital horn. So for the second view, what we do is we tilt it slightly posteriorly, and these are the structures which we get. So this is how the brain is cut open and we see. So we keep the probe on the move it slightly posteriorly, and what the kind of image we get this kind of image. So this is an animation and this is the actual image which we get. So again, we need to identify the structures in these cases. So first is the interhemispheric fissure. Then there are 2 parallel lines running in between the lateral ventricle, that is the corpus callosum. You need to identify that structure to rule out the corpus callosal agenesis. On the either side, the hypoechoic structures, what we see is the lateral ventricles. You have to see the whether they are dilated or not, whether there is any pathology seen or not, whether any hemorrhages are there or not. You can identify on the size of the lateral ventricles. Below that, where sometimes you see a hypoechoic structure, that is the persistent cavum septum pellucidum. Below that, we see the caudate nucleus, and below that is our putamen. So these are all the structures. So in cases of hypoxic ischemic encephalopathy, sometimes you see an hyperdense areas over the caudate nucleus or putamen. These are the on the front. Since we are cutting the brain on the frontal horn side, so we see the frontal horns, and we see the Sylvian fissure. So this is the Y-shaped fissure which separates the frontal or parietal lobe from the temporal lobe, and try to maintain a symmetry between both sides. So it will be like a Y structure. So you can see this line, and then a Y-shaped structure is identified. Laterally 2 Ys are coming. You try to maintain both symmetrical, so you get a very symmetrical image. So this is the Sylvian fissure, and below the Sylvian fissure, what we see is the temporal lobe. So these are all the structures we need to identify on the brain ultrasound. First, try to use it on the normal babies, and gradually as you gain experience, you will be able to differentiate between normal and abnormal. We'll have a separate lecture for the abnormal views also. So now when we cut open or the beam passes through the foramen of Monro, these are all the structures what we see. So now how this frontal part we don't see, we see exactly between the parts from the when we are passing the beam through the foramen of Monro. So it is also called as the Trishul view because you can see the one central and the third one. So it is also called as the Trishul view. So what all structures do we identify over here is the lateral ventricle. You can see this is the lateral ventricle. This is the right side of the marker. So this is the right side of the baby. This is the left side. You can see there is slight asymmetry between both the ventricles. That is, in this case, it is physiological only. Here, the foramen which is connecting is the foramen of Monro. Okay, so this is the foramen of Monro, lateral ventricle, foramen of Monro, which connects the lateral ventricle to the third ventricle. So these are the third ventricle which we see. So in cases, this is a very important point, because if we see any bright spot in front of the foramen of Monro, then there are chances that the baby is having an intraventricular hemorrhage. So usually the choroid plexus starts posterior to this. Other structures which we see is again caudate nucleus. In between the caudate nucleus and the putamen global pallidus, we can see the internal capsule, then putamen and the globus pallidus. So these are all the structures we commonly identify in the view which is passing through the foramen of Monro. So these are again the parietal lobes, and below is the temporal lobe also. This is the Y-shaped structure, is the Sylvian fissure. You can see these both are symmetrical on either side. Then when we cut open the ventricle between the middle part of the ventricle, so these are the structures which we can see. So again, what we see is the lateral ventricles. Below, now you can see an hyperechoic area over in the inside the ventricle, that is the choroid plexus. Below we can see the third ventricle, and lower now we will be able to see the cerebellum also in this view. Okay, so this is the common. Again, this is the interhemispheric fissure. The two parallel lines are the corpus callosum. This is the parietal lobe. Then you can see the in lower below the Sylvian fissure is the temporal lobe, and posteriorly is the cerebellum. Now going still posterior, we see the posterior horn of the lateral ventricle. So these are named anterior lateral ventricles, anterior portion, middle portion, and the posterior portion of the posterior horn of the lateral ventricle. Okay, so these are the structures which you can see. So on actual image, we see the lateral ventricle. Inside the lateral ventricle, we see the choroid plexus, which is an hyperechoic area, and below that we see the cerebellum. Again, the interhemispheric fissure and all those is present. This even we can go a step behind on the more sixth portion, that is directly seeing the brain matter. That is the sixth view. We are crossing the occipital horn itself. Now we have completed all the coronal view. Now we are looking at the sagittal view. So how the probe is kept? Now the marker is kept anteriorly, as we had learned previously, that either the marker is on the right side of the baby or on the anterior side of the baby. So now the marker is kept on the anterior, facing towards the nose, and here we tilt the probe from left to right. Okay, so first we get the view from the centralmost part. So this is the marker facing towards the nose. Here also you can see the marker is facing in front. So this is how you keep your marker on the baby on the anterior front panel. Then these are the, one is the centralmost, the true sagittal or the midline view. Then we go towards the laterally on both the sides. So hence total of 5 views we get. One is the central and 2 on either side. So how do we rotate the probe? With the marker pointing anteriorly. So this is how we get the image. So your marker is there, and this is the all the structures that we see in the brain. So how do you identify whether you are in the actual center or true sagittal or midline view? We see this bright structure, and it is called as the lady in dress sign. That means that an English lady is wearing a hat and the long gown. So this is like this view is called also as the lady in dress view, or the lady in dress sign. So you can see this lady in dress sign. So if you see this kind of hyperechoic structure, that means that you are actually in the true midline, and this is how you identify it. So what all structures do you see here? So this is the corpus callosum with the two lines which we are parallel lines which we are seeing. Now you can see the complete corpus callosum. If so there sometimes can be complete or partial corpus callosal agenesis. So on the coronal view, you might see the two lines anteriorly but not posteriorly. But here you should confirm, as I told you, if there is any pathology, you should confirm it in at least 2 views. Second is, this is the cavum septum pellucidum. Then you can see the foramen of Monro, which is connecting to the third ventricle, posteriorly is your cerebellum. This is your third ventricle, which is being connected to your below is your fourth ventricle through this aqueduct of Sylvius, and in front of the fourth ventricle is your brainstem. Okay, so these are the structures which you identify in the true midline or true sagittal views. Then when you move your probe, tilt your probe slightly towards laterally, so these are the structures that you will be seeing. So this is a very important view, especially in the preterm babies, as this is in this view, what we see is the caudothalamic groove. So this is the caudate nucleus in front. Here you can see this is the caudate nucleus, and posteriorly this is the thalamus. Okay, so in front of the thalamus there is a caudothalamic groove. So usually your choroid plexus starts from the caudothalamic groove and never crosses it. But if there is an intraventricular hemorrhage, the hyperechoic or hypertense area is seen crossing the caudothalamic groove, your choroid plexus. That means there is a bleed or intraventricular hemorrhage in the choroid plexus. So this is a very important landmark. Okay, so as I told, this is the choroid plexus, and what we had seen is the lateral ventricle. So it has an anterior horn, middle horn, posterior horn, and even the inferior horn of the lateral ventricles. Still moving further laterally, what we can see is the brain parenchyma. This we need to see especially for the babies whether they are having periventricular leukomalacia. So here we see all the brain lobes, frontal lobe, in the middle is the parietal lobe, posteriorly is the occipital lobe, in between is the Sylvian fissure separating the parietal and frontal lobe from the temporal lobes. So this is when we see more laterally. So once we have seen the right side, then we go towards the left side. So from true sagittal, we go slightly towards the right, then still further to see the cortex view, and we repeat that two views on the other side, that is the left side also. So this completes our viewing of the sagittal views. Now the less routinely used views are the posterior views, the mastoid and sphenoidal views. So on the posterior view, what we do is we take the probe, lift the probe, and move the whole probe towards the posterior fontanelle. So this is the place where we see for the structures. So we move the probe on the brain, it looks like this, and when we cut open what the beam passes through the brain, the following structures can be seen. So we can see the interhemispheric fissure, then the occipital lobes, then the lateral ventricle, and the third ventricle. So these are the structures. So if we want to see some of the more posterior structures which might sometimes not be very visible in our anterior frontal view, then we can see the more posterior structures in the posterior fontanelle axial view. Okay, here the probe is kept again on the right side of the baby marker. Then from that we move towards the mastoid view. Here we keep our probe behind the ear. We search for the sonic window, and here the marker is, we are rotating the probe so that the marker is facing anteriorly in this case. Okay, so here you can see that this is the marker, it is facing anterior to the baby, and we have kept the probe behind the ear of the baby. So this is the place. From here we can see all the structures. So the beam cuts through this section. So from this we usually see the cerebellum over here. So here we can see both lobes of cerebellum, that is the cerebellar hemisphere, both the lobes. In between is the cerebellar vermis. Then in front of it is the fourth ventricle, and still in ahead of that is our brainstem. So this is a good view to see if you are suspecting any lesions in the cerebellum. Then what we do is one more is the sphenoidal view that we'll be talking in our next few slides. So now, as we have seen the structure of the brain, we sometimes do the Doppler also in the brain. So commonest two arteries which we see are the anterior cerebellar artery Doppler or the middle cerebellar artery Doppler. So how do we do it? So first we have to see for the true sagittal plane, anterior cerebral artery Doppler, we keep our marker on the facing towards the right. We see for the lady in dress appearance, and then we slightly tilt on any of these right or left side. So here we rotated the probe with a marker facing towards the nose. Then when it cut open, we see this is the anterior cerebellar artery, which is taking a curve in front of the corpus callosum. Okay, so this is the anterior cerebellar artery, and these are the again branches of the anterior cerebellar artery. So here you can see the pulsating anterior cerebellar artery. So we have to see the for the lady in dress appearance, we have to slightly tilt on either right or left side, and over that you have to put your color flow. So this is the color flow window which you apply, and you can see the very well pulsating cerebellar arteries, anterior cerebellar artery. This is how you see the pulsating cerebellar artery, anterior cerebellar artery. So how do you do it? You put a color flow, then you put a gate. So you press your PW button, that is pulse wave Doppler button, and you have to, there will be a gate where the two parallel lines or a square will appear. You have to put that two parallel lines as parallel to the blood flow as possible, because we had previously studied about the angle of insonation. If we to keep it too angulated, then the waveform will not appear properly. So what we are doing is, we have identified this true sagittal view. We have put a color flow meter over here. We can see the pulsatile arteries. Now we will apply. You can see that there is this is the line which is coming. This is a pulse wave, and when we press it again, we get a very beautiful pulse wave form. So now how do we measure it? When we in the pulse, this PW, then we have to freeze it, and we have to select the RI on the machine. From that, we have to see the peak systolic velocity, that is the highest point, as well as the lowest point, that is the end diastolic velocity. So here RI is 0.65. So between 0.55 to 0.8 is normal. Anything above or below signifies has some issues, which we'll be talking about. So this is how you see for the anterior cerebral artery Doppler, from which you measure the RI or the PI, that is resistive index or the pulsatility index. Second view is the, which I talked about, is the sphenoidal view, in which you keep the probe in front of the ear. Okay, so you from the anterior frontanel, you move the probe to the sphenoidal frontanel, and you keep your marker facing anteriorly. So this is how you keep it, marker pointing anteriorly. So this view is used for the measuring of the middle cerebral artery. Okay, so here you can see that this is the middle cerebral artery. So nice pulsation can be seen, and again your angle of insonation would be as parallel as possible. So this is the MC, what we can see. On this MC again we put our gate. So this is the gate, and then we will get the waveform. Okay, so this is how you do for the middle cerebral artery. So this is the waveform. Again, you see, these are the pulsatile structures. This is the artery, you can see beautifully in red. You put a gate over, you can see we are keeping a gate over here. And once we press it, then we get a waveform. Okay, so based again on this waveform, we measure the PI or the RI of the baby. So these are the cases in which we see an increase or a decrease in pulse RI or resistive index. So commonest periventricular leukomalacia, cerebral edema, intraventricular bleed, we see an increased RI, but in babies with birth asphyxia, we see a decreased RI. So these are the commonest few things for which we see. So even in PDA, we see an increased RI. So there are confounding factors like that also. So commonest, when we see an intracranial bleed and hydrocephalus, if there is an increased RI, that means the pressure is increased. And in babies with birth asphyxia, because of the loss of the cerebral autoregulation, we see a decreased RI in this kind of babies. Okay. So these are the various sources from which I got all the images. Few of are from mine and Dr. Vishal's center also. So thank you everyone for the patient hearing. If there are any questions, I will be happy to answer them.
Thank you so much, Kunal. I think it is very informative session regarding the hair ultrasound. And again, those who are want to do the hemodynamics, I think is a perfect start, to start with the hair ultrasound. It's not that much difficult as compared to the echo. Any question from the audience, delegates? Any question? If there is no any question from the delegates, so I think it is a nice presentation, like regarding the normal hair ultrasound. You already discussed all the windows, including anterior, posterior, and mastoid and sphenoid. And I think it is a perfect start. If someone can start someone want to learn the new hemodynamics, and those who are doing level 3, level 2 NICU, I think it is very helpful. This head ultrasound, so you can easily assess not only the brain structure, but also like you can assess the pressure and everything. Anything from the Nirmal sir, if you want
Vishal,
to add something.
Kunal, I think you have covered it very well. The normal views at the head ultrasound. I will only emphasize that those who have got the machine in their unit, they should start practicing this views. The more and more we'll practice, we'll learn. So start with the normal babies first, and then where there are abnormality, but it has to be practiced. I think Kunal has covered it theoretical aspect very well, and we will learn by practicing only. So it is definitely a very good cover has been done. And Vishal, thank you very much. I think that's all what I want to say.
Yes. Thank you so much. So Kunal, can we end the session?
Yes. Thank you.
Yeah,
Thank
yeah.
you so much for the
Thank you,
opportunity.
everyone. Thank you.
Thank you,
Thank you,
Kunal.
all
Thank you,
the
Vishal.
delegates. Yeah, thank you, sir, Nirmal sir, to join us.
Thank you.
And Jatin by everyone who, our EB member and everyone. Thank you so much. You can end the session, Monica.
Thank you.
Momita, you can end the session.
Thank you so very much, sir, and thank you so much, everyone, for giving us this opportunity to host this session. So, for now, without your permission, I'm closing the session over here, sir. Thank you so much.
Thank you.
Thank
Bye.
you. Thank you. Bye.
Bye, sir.